physiotherapy department into the lectures. It's a very interesting lecture because it's about the technique that has been going on in our hospital, and it's important for everybody to be aware of. Okay? I will start and then tell you. Thank you.
Hello, good morning. So happy to actually deliver next talk about physiotherapy services. And I appreciate the update, I would say, because we tried using the technique that we've been practicing in the hospital. We would just like to keep your attention on this, that we have such kind of modality in the hospital as our services. I will present today the topic along with Kevin. Okay, let's start. So, regarding the content, we would like to share a few information with you about what is the deep brain imaging. Of course, we have to talk about acupuncture a bit, but then idea why do we need deep brain imaging, what pain and myofascial pain has to do with such kind of modality. And we will talk about local twitch response, which is important. We will see what does it mean, how to elite it, and we'll present one video, and I will also contribute a bit, and I will show you how to actually do the meeting itself. Okay. So what is important, dry cleaning is recognized internationally, so it's not a new technique, it's been the technique which has been developed since a longer time, and few federation and association of physiotherapy, they recognize this modality in the international level. Deep dry needling might be performed by trained physiotherapists, and later I will say who in our hospital is trained to do it. And basically, deep dry needling we use for the myofascial pain, kind of pains that we might have in the muscle. So mostly it works for muscular pain, and that's what we will actually focus on today. Why do we have pain in the muscles, and what are the trigger points that we'll talk about? So to needle patients, basically we use the dry needle, and there is no medication. Deep dry needling came from the idea that we can actually do injection with saline into the painful muscles, but then they made some researches and they came to know that if you put either needle or needle with the injecting actually saline, it is the same result. So we kept it simple things like, and we just stayed without saline and pain medications. So basically we insert needles into painful spots, which are known as trigger points or taut points in any muscle. It might come in any muscle basically. That's what we're talking about assessment as well. Needling comes from Western anatomical or physiological principles. It's based on this. Should not confuse with the traditional Chinese medicine, which is very famous of acupuncture, and it's quite effective. It's fast. You will see how fast we can do actually treatment. But of course, we can continue with several sessions. The most important aims of deep dry needling are to reduce muscular pain, release tension, release spasms sometimes as well. We want to reduce basically the pain and improve the control of this pain by the patient. And we would like to, putting the needles itself, we normalize, seems like that we normalize actually the electrical dysfunction of the motor end plates, because they are quite tense, and that's why we have actually trigger points. And we will see probably in the next slide that the trigger point itself is a part of the muscle, actually is a fiber of the muscle which is shortened. It doesn't mean that the whole muscle is shortened. It's not like this, just some partial part of fibers that are tense, and probably all of you might know this kind of trigger points, that if you squeeze here in this area in the upper trap, some of you, if you work for example too much using laptops or computers, you might have shrugged shoulders, and definitely all of us we can develop such kind of trigger points. So this is most probably most famous trigger points. Needling itself goes with the treatment ideas for releasing the pain, and we have like 3 ideas of release the pain, stretching this muscles or this structure of the body, and strengthening. So as you see for the release, actually we have a few different techniques. So starting, let's say, this is very easy because of course patients they can do themselves, like for example using such kind of roll when we have any kind of trigger points in the battle, but then we can use also trigger point therapy, and finally of course we can use also needling. So there's all 3 things we can use, and then we can continue and teach the patient actually to do stretching and then strengthening, because we want to use as much modalities as possible. I mean, not too much, but most effective. So if we combine them, I think that gives good results. And a comparison acupuncture deep brain needling. Just would like to say something about this. I don't know much about acupuncture, honestly saying, almost nothing. To do deep brain needling, we don't have to know the knowledge about acupuncture itself. But basically, that's what you see even from the very beginning. Here you can see meridians. A few of our friends, they can definitely say a lot about this. And here we can see typical maps of trigger points. I don't know if you are aware, but in the 70s, 80s, and 90s, a few release of big textbooks, Travel and Simmons, and they recognize trigger points. And basically, these textbooks, they are like localizers. I mean, they give information where how to localize the trigger points. So let's say we have a few trigger points, and also the red spots are the referred pain. So treating actually one place in some part of the muscle that might release actually tension in few other areas, which are called as a referred pain. So talking about comparison origin for the acupuncture in traditional Chinese medicine, dry needling is Western biomedicine. Location of points where we put needles for the traditional Chinese medicine is meridians, and few additional non-meridian points. For in dry needling, we are based only on trigger points, so we have to know how to find the pain. Sometimes actually it's easy. Sometimes these points they are like blatant that the patient actually doesn't know about the existence of this point. But when we press it, actually then sometimes we can even see this jump test. So the patient is more awake and recognizes the pain that he might have for some time. And needles itself, actually they are exactly the same. We use same needles like for acupuncture. So deep dry needling and acupuncture, they're almost same needles for acupuncture. We can use also needles made out of gold and silver. And practitioners, maybe let's talk about practitioners. So here in the hospital, regarding acupuncture, we have two practitioners. This is Elizabeth and Ben. So definitely they are good people to refer actually patients for acupuncture, and probably acupuncture is way bigger knowledge than deep dry needling, and it's way older and it works. And deep dry needling therapists, which are in the hospital, this is Kelly, this is Maureen, and this is myself as well. And so to perform any kind of activities regarding needling, which is invasive technique, and definitely we need to have a training. For physiotherapists, we do not, as I said, we do not require training regarding acupuncture, and deep dry needling has been performed by physiotherapists, osteopaths, chiropractors, medical doctors as well. And regarding acupuncture, people that are trained, licensed, and registered with global practitioner traditional Chinese medicine. Talking about ideas and, let's say, indicators of the success of the treatment is traditional Chinese medicine is looking for energy. So thinking about energy which is circulating in meridians, just to calm it down. And for deep dry needling, we are looking for the LTR, which is local twitch response. So you will see what is this on the video. Depth of insertion, of course, it varies, and it might be deep, and that's what characterizes deep dry needling. We just go deep into the muscle. We don't want to stay in the skin. We want to put the needle deep inside. That's why we have different lengths of needles, even up to 10 centimeters, because of course it depends on the area of the insertion. It's not everywhere we use 10 centimeters, but we might use 2.5 centimeters, 4 centimeters, 7.5. So it depends, of course, from the build of the patient itself. And acupuncture as well goes deep, but probably has much more actually shallow points to insert the needle. And duration of the insertion for the acupuncture is 5 to 40 minutes. I heard about as well about even long insertions. Here I had some information from the book, from the scripts, that even it might be well for a few days. And deep dry needling stays, as you see, 30 seconds to 5 minutes. Some people, they say if we have really painful patient and he's acute, we might even look for this 7 times when we see the local twitch response, which might occur quite fast. And the intent itself is just to balance qi and in acupuncture, and in deep dry needling is to release and relax the end place of muscles, just to get the trigger points actually released and relaxed, so they will not cause any kind of, let's say, even postural problems. Okay, so how does it work? we have something which is called needle effect. We want to insert the needle, which gives some stimulation that gives a response from the body in the way of healing responses, because we have a response from trigger points. We have different neurochemical reactions that we'll talk about them right now. So the healing effect is. Let me come back to this one. So regarding the effects of needling, any kind of needling, deep dry needling as well, we want to increase capillary permeability, which we see actually the redness, so it might give the response already on the skin. We can use the potential of injury, so actually the body has the strength to reheal and create galvanotaxis. We have also idea of gathering of collagen. So when we put the needle in, for example, we use one of techniques when we twirl the needle, it might give some good healing neuromodulations in this area of the body. Definitely it might give and bring some anti-inflammatory reactions. And what is important, we have endorphins that they reduce pain and then they decrease the perception of the pain itself. So that gives an analgesic effect. And this is due to this that the needle itself follows the muscle pain gate control theory. When delta fibers, actually they are faster than C receptors, and that's why actually the pain, which is for a long time, that might be decreased, and actually in a fast way might be reduced. And so once again, we're talking about trigger points because everything is about muscle pain. Muscle pain comes because there are some muscle touts which are called trigger points. So these trigger points, they might give some different symptoms, and mostly it's intraspasm, muscle rigidity, guarding, and it might result in immobilization because that's a result of trigger points, or actually they can as well cause the trigger points. So it's like a bad circle. So we want to break it, put in the needle in. That's maybe a bit more about trigger points itself. I believe a few of our friends, they were already giving talks before in the past regarding trigger points, but maybe just to remind. So as you see, we have muscle, we have different fibers, and some of them they are just out, they are just shortened. So basically, we don't want to insert maybe one fiber because it's not possible. But the area where the muscle touts might be available, and actually it's quite easy to recognize because we just palpate the muscle in different parts of the body, of course, and according to this where the pain is, and then we can quite easily actually find some nodules as well. Yeah? So when we squeeze this noodle, we have something which is called the jump sign, might be there. So the patient might just jump because of the pain when we squeeze it. Then patient is of course describing the pain. How we can confirm that was the trigger point because we had the local twitch response if we would put the needle in, and then that's what I was saying about mapping and localization of trigger points. It might give also the referred pain. So when we press the trigger point, it might give some answer which is the referred pain, even in the different part of the body. I mean, close by, but not exactly in the same place where we actually squeeze this or push this muscle tissue. Definitely due to trigger points, we might have restricted range of motion because muscle is shortened, so we cannot, for example, do full movement of the arm, let's say. Patients, they complain as well about the muscle weakness because, again, they are a bit weaker due to this that they cannot elevate the whole power because, for example, the range of motion is restricted. And we have additional phenomena like tingling sensation. When we squeeze them to the trigger points, we have goosebumps, sweating. Everything what actually creates trigger points mostly are this overuse, overload, and overstretch of muscles. And what is important maybe at the end, I would say that trigger points, they might be affected also with metabolism and nutrition itself, or malnutrition. And malnutrition comes as well probably with this that there is lack of the oxygen in the tissue, or tissue is somehow actually squeezed, clamped, and there is not enough oxygen that creates in the result the trigger point. Talking a bit more about trigger points, like you see we have different muscular myofascial pain, musculoskeletal pain. So all of this is supposed to be actually assessed in the way of palpable, finding the palpable bend. We can also check the movement, which is described as a pluricentric work. We can check the stretch, if it's painful or not, and we can see what is the range of motion itself. Finally, let's talk a bit about indications. So basically, there are some contraindications, there are many indications actually, and we can use for many of our patients. We were talking yesterday with Kelly about which patients we can do what. We can actually use needling for inpatients, outpatients, but maybe let's focus on this. So with, let's say even paraplegic patients, we can work with the painful shoulder. We can work with people that are, let's say, outpatients after the surgery or before the surgery, not during, when they are inpatients right after the surgery. Right after the surgery, we can't do it. We can do needling within 12 weeks. Yeah. So as you see, even simple idea like even using crutches or frames, that of course we see on a daily basis that may create some trigger points in the upper gilbert. So why not? We can use it as well. We can stretch. We can do different things. We can use heat, but why not to use needling as well, which is quite direct and gets exactly there where actually heat needs some time to get into this. We can also work with the hemiplegic patients as well. Some unstable shoulders. Here actually I was giving some ideas about patients. Here even we're thinking about maybe patients like from ICU8 where the exaggerated breathing pattern is, so around the shoulders they're contracted, or some restrictions they might be occurred in muscles as well. And also for the muscles, like orbitals after the total knee replacement. So this is just a small idea where we can use needling. And now maybe let me introduce Kelly again, and let her talk about methodology.
Talking about the technique of dry needling and basically just bringing it together with any risks that you might have. So I'm just going to show you on Andrew today how we do dry needling. So it is actually quite simple. We do use a clean technique, as sterile as possible. It's really safe to use with most patients, and obviously you're having a patient that's complaining of certain symptoms, and that's what you're trying to do. So Andrew was saying that he's been working on his presentation so much, so he's got tight shoulders. So we're going to treat his upper tracts. So these are the needles that we have. They obviously are needles. They have no, they're not like an injection that you'll use, and they in a blister pack. You only use the needles once. We never reuse needles ever. So, you so nervous? Alright, so we can use alcohol just to clean this up. Alright, so basically we're going to be feeling inside the muscle. Really feeling the trigger points, so we can find one in here. Alright, so we're just going to clean that area, nice and easy. And we'll just use one finger, one hand technique. And it comes with a guide tube as well, so we can actually direct it straight into that muscle. Usually you would be in a different position. So I'm going to use the pincer grip here with the muscle. Just nice and straight. Alright, so you're finding exactly where he's nice and tight. Okay, and you're going to direct it towards my bone. You're not directing it to his bone. So you're going to put it straight through the muscle. Alright, and then it basically stays in there, the skin. And you'll put it into that trigger point that you will find. And if it's an active trigger point, that patient will be complaining of twitching by themselves, even without the needle. But once you put the needle in, sometimes you can also get that twitch response as it's sitting inside there. So we can try and stimulate it. We can do different things, different techniques called fishing, or what we call fenestration, which is actually just hitting the needles, is getting the vibration through the muscle. And then that's that. And out. Well done. Alright, so when we're doing, I'm just going to show you a video now. Yeah. So obviously when we're doing the needling, we're looking for the local twitch response. That is an indication of a good response for our technique. So you can see in this video when the muscle, like it's fasciculations in the muscle, and you get little twitches from the needle being left in there. So with this patient, which is a little bit rare, it's after a run, it's actually a post-run marathon. So the muscle itself is very activated, there's huge amounts of electrical activity inside the muscles. And you can see just by putting the needles inside those stimulated muscle fibers, that's what they're doing, they're getting all those local twitch responses. Alright, so as we say, we're looking for the local twitch response. Usually we're looking for more than two twitches once we put the needles inside. The more twitches we can get, some articles say up to 20 on one needle if you've got a very active trigger point. And then obviously that helps to regulate all the chemical changes that have happened, the electrical changes that have happened inside that muscle. Alright, so dry needling techniques. Obviously we have deep dry needling, which is what we've just shown you, putting it into the trigger points inside the muscle, as well as superficial needling. So both are a little bit different in how they're working. The deep dry needling is going into the muscle, we're trying to get that local twitch response, whereas the superficial needling is more to use with scar tissue or with connective tissue that you're trying to use as well, trying to loosen up any cross frictions that you've got in those muscles or skin. Alright, so when we're doing dry needling, we have to be trained to do these techniques safely. We want a clean, dry area, and we want to make sure that I've got either clean hands or wearing gloves. And we want to prepare the site so just an alcohol swab is nice and effective. There's usually no bleeding afterwards. That's why sometimes you can be allowed to not use gloves. And then obviously you want to make sure that once you finish with your needles that you're disposing of them safely. Alright, so looking at some contraindications. When you've got a patient with a needle phobia, we've obviously got lots of other techniques that we can use, and if a patient really does not like needles, this is not going to work for them. They're not going to be able to relax at all while they're trying to do the needling, which is the whole point of the technique. So if you've got an unwilling patient, either because of beliefs or they're scared of the needle, going to it, we want to get consent. International guidelines are saying that we need to get informed, written, signed consent when we want to do needles, just to make sure that if there's any issues, the patient knows exactly what's coming and if there's any problems as well. And if they've had any bad reactions to needles in the past, if they've passed out or if they fainted or because of fear or whatever it is, we need to know about it. We won't use the needles on anyone with anticoagulant treatments, high doses of anticoagulant treatments, and obviously thrombocytopenia as well, so excessive bleeding that they might have. And also if the patient has lymphedema in their legs or lymphedema anywhere in their body, post-lymphectomy, we also won't use this technique. So relative contraindications, cautions that we'll look at. Abnormal bleeding patients that are obviously immunocompromised, from cancers to HIV and acute rheumatoid arthritis as well. You can see the list here. Diabetes, as I say, is precautionary. If you've got a patient that doesn't have any sensation in their feet, you're not going to use the needles. They're not going to feel it anyhow, so we avoid it. And also in the first trimester of pregnancy, it's not advisable to use the needles. In epilepsy, children under 12, and obviously over joint replacements, breast implants, pacemakers, where you could be touching the machinery that's been put in there, or or the implants that have been put inside. And then obviously, as Andrew said earlier, 12 weeks post-surgical, just because of the risk of open joint surgeries, we don't want to increase the chances of any infections in the body. So dry needling risks. There are some risks, but if you've been trained well and you know your palpations, you know your areas, and you know your anatomy well, it's not really a problem. Obviously, pneumothorax is probably the most common around the world of a risk. So obviously you need to warn the patient that if they feel any of these symptoms, or you know you've needled in the various areas around the chest or the pleura, that's, they know what to look out for in case of neurothorax. The blood vessel injuries, you need to make sure that you've located any arteries that might be in that area, so you're not going to pierce the artery. Obviously any nerve injuries, organs, and other risks that we might get. Sometimes patients get euphoria, they actually start laughing as soon as you put the needle inside. Andrew did a little bit of a giggle. And then any needling pain as well. So the needles are they are quite intense. So sometimes they might get post-needling pain, but if they know about it, then they're not going to get too worried about it either. And then, so we have certain areas that are restricted, obviously from the occiput to C3, the intercostal area of the pleura, any nerve bundles like the brachial plexus or the femoral arteries or femoral nerves, and then obviously the subclavius muscle we actually don't go near. It's got too many risky areas around it as well. How to improve our safety, proper landmarking, knowing where you're putting the needles in. They're very specific points where these trigger points are. They've been mapped out for us by Travell and Salmons as well. You're using your pincer grip if it's in a muscle that you can do a pincer grip. Otherwise, flat palpation on the flat muscles around the body. Proper positioning of the patient to bring the muscle up into a stretch as much as possible. And then obviously just to do your checks. So you do your active muscle tests before and after, checking for your outcomes of your technique as you've done it. Alright, so this just shows a little bit of the muscles that we do around the body. Obviously around the shoulder joint there's quite a lot of muscles. A lot of people have trigger points at the back of their shoulders, posterior capsule as well. The pelvic girdle, into your glutes, your cervical area, especially into your sternocleidomastoids, your scalenes as well. Into your lumbar area, which has been found, there's a lot of studies about dry needling post-backups with the spasm and the scar tissue that you do get there, but obviously nothing before 12 weeks post-surgical. And then obviously just to conclude, dry needling is just another tool in our toolbox, and it is always meant to be used in conjunction with other treatment techniques. We can't just do dry needling, so you'll do stretching, you'll do strengthening of the muscles, correction of their posture, and the needling is just there to help us to really relieve the patient's pain. You can resolve obviously any acute chronic pain, increasing the range of motion of certain joints, improving the function of impaired movement patterns. And then obviously there have been many studies done on dry needling. It is a new technique, so every year there's better and more evidence-based and high-quality studies being done. And then obviously you need to be a medical professional, and you can only do dry needling postgraduately. And it's very, very good technique for your patients. It is very effective. And as Dr. Neuro was saying, we have been doing it here at Neuro Hospital. And I think there are a lot of patients that have really enjoyed the technique, as well as the acupuncture as well.